You walk into a patient's room and they are visibly panicked. But when you check the monitor, their oxygen saturation is sitting comfortably at 94%. The question you have to answer immediately is whether this is simple anxiety or if their airway is about to fail. I'm Brooke Wallace. Today, we are taking textbook respiratory theory and applying it directly to bedside decision-making to prevent your patients from coding. Before oxygen levels ever drop on a monitor, the body physically works overtime to keep them stable, a process called compensation. Look at the patient's neck. If you see the sternocleidomastoid muscles actively flexing with every breath, they are already pulling deep into their muscular reserves to force air into their lungs. This animated line graph plots a respiratory rate steadily climbing from a baseline of 18 up to 26. That trend is the earliest and most sensitive predictor of a respiratory crash. If you wait for the SpO2 monitor to drop, you have missed the opportunity to intervene before the patient's physical reserves are exhausted. Spotting the work of breathing reveals the crisis before the monitor alarms. That 94% reading on the pulse oximeter is a trap. It provides a false sense of security while the patient's actual tissue oxygenation and physiological reserves are failing. This schematic of a hand shows peripheral blood flow retreating from the fingertips. We test this directly at the bedside. If you press the nail bed and it takes longer than 3 seconds for the pink color to return, or if their extremities feel cool to the touch, their peripheral perfusion is failing. We can measure this shrinking volume using the words percent assessment. If a patient who normally speaks in full sentences is now reducing their speech to 1 or 2 broken words between gasps, they have exhausted their lung reserve. Oxygenation is a systemic process, not an isolated monitor reading. Tracking these physical signs will reveal silent hypoxemia long before the alarms trigger. Eventually, a clinical shift occurs where a struggling patient stops looking anxious and suddenly becomes lethargic or confused. They are not finally resting. They are experiencing carbon dioxide poisoning. This cross-section schematic of the chest cavity illustrates paradoxical breathing. The diaphragm has completely exhausted itself. Instead of expanding to pull air in, the chest wall pulls inward while the abdomen pushes outward with every attempted breath. So what happens if you apply 100% oxygen to a lethargic, paradoxically breathing patient without adding positive pressure? You completely knock out their hypoxic drive. Their brain senses plenty of oxygen, stops sending the signal to breathe, and their respiratory rate drops entirely. Mistaking CO2 narcosis for normal fatigue leads to a lethal misapplication of standard oxygen therapy. Recognizing this exact shift dictates the correct intervention. Once you recognize mechanical failure, you escalate therapy. You bypass the standard nasal cannula entirely and initiate high-flow nasal oxygen to support the patient's respiratory effort. Next, call for a portable ultrasound at the bedside. You use this to rapidly rule out physical obstructions in the chest cavity, checking for severe fluid overload or a pneumothorax. This mechanical diagram shows positive pressure from a BiPAP mask. The mask physically stents open the collapsing airways and forces the trapped CO2 backward out of the respiratory system, preventing the need for emergency intubation. Physical mechanical failure of the lungs requires mechanical positive pressure interventions. Passive oxygen delivery is no longer enough to save the airway. With bedside interventions in place, you activate your team. We use the SBAR framework: situation, background, assessment, and recommendation to communicate clearly. This comparative checklist graphic shows the difference in reporting styles. Saying the patient looks bad is subjective and gives the team nothing to act on. You must report objective data, specific respiratory rate trends, a delayed capillary refill time, and the physical presence of paradoxical breathing. Document the precise moment the clinical picture shifted. This establishes the timeline the physician needs to justify an immediate transfer to the ICU. To recap, distrust the SpO2 monitor, track upward trends in tachypnea, spot early shifts like lethargy, and escalate using objective data. I'm Brooke Wallace. Head over to our website for more resources, and I'll see you on the next shift. Hey, thanks for watching my YouTube channel. Don't forget to like and subscribe and leave a comment. Let me know what topics you want to see more of and how I can help you become the super nurse you were born to be. I hope to see you here again real soon.